Did you know the whole idea of mixing physical activity and medicine goes back, well, thousands of years?
Really? How far back?
We're talking 5th century BC. There was a Greek physician, Herodicus. People often call him the father of sports medicine.
Okay.
Apparently, he came up with specific treatments just for athletes. So, thinking about healthcare for performance and recovery, even then.
That's quite something, isn't it,
Yeah.
when you think about it?
Exactly. Now, fast forward, and you land in today's world of orthopedic sports medicine surgery. It's incredibly complex, highly technical,
A world away, I imagine.
completely. And the challenge now isn't just knowing the science of an injury, it's about mastering the sort of intricate art and the really precise skill you need to operate inside a joint, often using minimally invasive methods.
Right, the hands-on part.
Yeah. So the big question for us today, and really for the whole field, is pretty basic. How do you actually train someone effectively? Not just the book knowledge, but that nuanced, practical expertise you need to be a truly skilled surgeon in this specialty. How do you get from theory to, well, mastery?
It's a fundamental challenge, definitely.
Welcome to the Deep Dive. I'm your host. Our aim here is pretty simple. We take a whole load of articles, research, expert views, and we boil them down to the key insights you need to get up to speed quickly and hopefully in an engaging way.
That's good.
Today, we're diving deep into how motor skills are trained, specifically in orthopedic sports medicine, which is, a tough area. We've gathered insights from various experts to shed some light on it.
A really important topic.
And joining me to help make sense of all this is someone who's brilliant at distilling complex information. With loads of experience across different fields and a real knack for linking theory to practice, he's perfectly placed to guide us through the tricky bits of surgical training. Welcome.
Thank you. It's genuinely great to be here and dig into this vital area of professional development.
Fantastic. Right, let's kick off with a quick rapid-fire round. 3 key questions just to map out where we're heading. So, based on the expert work we've looked at, beyond just being good with a scalpel or an arthroscope, what really makes a skilled orthopedic sports surgeon today?
Well, it's fundamentally a role with many layers. It goes way beyond just the technical skill. The sources are very clear. You need that solid grounding in general orthopedics, obviously. Then you need specialized sports medicine knowledge,
Mm-hmm.
things like biomechanics, recovery science, even anti-doping rules.
Okay.
And crucially, a really well-developed set of non-technical skills.
Mm-hmm.
So we're talking communication, working well on the team, leadership, being aware of the situation around you and making solid decisions under pressure. These aren't just nice-to-haves. They're absolutely core to patient outcomes.
That paints a much broader picture, doesn't it, than just the surgery itself? Okay, next one. How do the basic principles of learning any physical skill, say, perfecting a tennis serve, playing the violin, or, doing a delicate keyhole surgery, how do those principles apply directly to training surgeons?
The science of motor learning gives us a really useful way to look at this. You can draw direct lines. Ideas like how we classify skills. Are they single actions, a sequence, done in a stable environment? Understanding how people learn in stages. The thinking stage, the practice stage, the automatic stage.
Right.
And applying specific ways to structure practice, like thinking it through, picturing it, saying it out loud before doing it. These are all directly transferable and, frankly, essential for building surgical expertise.
That connection between, say, sport and surgery is really interesting. Okay, last one for now. Looking at things today, with technology like simulators evolving so fast, different training approaches from hospitals, universities, even industry players, what are the big challenges and the key things to think about when you're trying to set up effective, properly certified surgical training programs now?
Right, this gets into the nuts and bolts of designing the training itself. You have to think about the curriculum, and that's more than just a list of topics. It's a whole plan. You've got to figure out how to bring in and check new tools like physical models or VR simulators work properly. How do we actually measure if someone's competent? Using objective tools like rating scales or structured assessments. And then ultimately, how do we set up certification so it genuinely guarantees a surgeon is ready, not just technically skilled, but has good judgment and can handle complexity. It's a big job trying to formalize and standardize what used to be much more of an apprenticeship thing.
Yeah, standardizing something that still feels like it has that art element to it. Let's really get into that first point you made, the multifaceted nature of the modern orthopedic sports surgeon. Our sources, especially material in Chapter 1, really seem to hammer home this idea that it's about more than just being good at the operating bit.
Absolutely. Professor Kurosaka's group and others mentioned really stress that competence in this area is built on constantly learning, rigorous hands-on training, ongoing checks, and crucially, sharp decision-making. They use that useful triangle pearls idea to show the blend needed.
Right, the triangle.
At the bottom, you need that solid base of general orthopedic surgical knowledge, the basics of trauma, joint replacement, and so on. Then you build on that with the specific, specialized sports medicine layer.
And what exactly is in that sports medicine layer? It's not just about knees, is it?
Oh, far from it. It's really understanding the athlete's whole world, their needs. So that includes understanding how athletic conditioning works, the huge role of nutrition and performance and recovery, different training methods, the psychology of sport, and yes, the things people might overlook like anti-doping rules and procedures.
Ah, okay.
You're not just fixing a mechanical problem, you're helping an athlete get back to performing in a very specific context. The surgeon really needs to get the demands of different sports and the athlete's unique physical and mental state.
That's a really important point. And then the third side of that triangle, those non-technical skills you mentioned, it seems a bit odd, maybe, to put communication right up there with surgical technique as must-have skills for a surgeon.
Perhaps it seems odd, but the sources are absolutely clear. These are mandatory skills. Just think about all the interactions. A sports surgeon hardly ever works completely alone. They're explaining complex diagnoses and plans to athletes who often have very particular goals and pressures. They're talking to parents, coaches, agents, physios, sports doctors, nutritionists, even pharmacists about medicines and supplements. If communication breaks down, it can seriously undermine even the best surgical work.
And the team aspect you mentioned.
Exactly. You're always part of a wider team. Good teamwork means understanding what everyone else does, respecting their knowledge, and fitting your surgical plan into the bigger picture of rehab and getting back to playing. Leadership comes into it too, especially if the surgeon is coordinating care or running a service.
Right.
Situation awareness. Just being able to notice and understand what's going on around you, whether in theater or in a clinic, is vital for safety and getting things right. And making solid decisions. Weighing up surgery versus non-surgery, thinking about the athlete's timing and future career that needs you to pull together all that knowledge and all those skills.
It really sounds like these non-technical skills are the glue, aren't they? Bridging the gap between just having the knowledge and skill and actually being able to use them effectively and safely in the real messy world. How do you even teach those? They feel more like things you pick up over years.
Well, experience is definitely crucial for mastering them, no doubt. But these skills can and really must be explicitly built into training programs. Things like using simulation scenarios, role-playing exercises, giving structured feedback on communication style, team-based drills. These are all methods that forward-thinking programs are trying out and putting in place. As Chapter 1 points out, sports medicine as its own distinct specialty is still quite young compared to, say, general orthopedics. That means standardization is still developing. And this really underlines why it's so important to keep studying not just the medical side, but also how to improve these personal and teamwork skills to give the best care and support athletes properly on their journey back to performance.
That gives us a really solid picture of the aim, the well-rounded surgeon. Now let's shift focus quite dramatically and get into the basic science of how we actually learn the technical motor skills, which are still obviously central to surgery. Chapter 2 talks about the science of teaching these skills, and it leans heavily on motor learning principles.
It does, yes. Authors like Professor Espargaro-Mendez and Professor Carahan point out that surgeons are often brilliant at doing surgery, but they might not have had any formal training in how people actually learn physical skills. Getting your head around the ocean of science of teaching, as they put it, is really key for trainers.
Yeah.
A motor skill is basically a voluntary, deliberate body movement that you get better at through practice. But, not all motor skills are created equal, and how you categorize them influences how you should probably teach them.
Okay, so based on the sources, how would you classify arthroscopic surgical skills? What type are they?
Right. Well, arthroscopic skills are mainly fine motor skills. You need very precise control of small muscles to do delicate things inside a joint with instruments. Crucially, they're seen as serial skills.
Serial.
Yes, meaning they're made up of a sequence of separate little movements performed one after another in a specific order to get the job done. Think about tying a surgical knot or passing a stitch. It's a chain of steps.
Okay, that makes sense.
And finally, for most planned arthroscopic operations, the environment inside the joint is relatively stable and predictable. So that classifies them as closed motor skills. This is different from open skills where the environment is constantly changing, like, say, returning a fast serve in tennis, or maybe doing emergency trauma surgery where things are very unpredictable.
That serial and close classification seems really important for designing training. A serial skill, you can break it down and practice the bits, can't you? And a closed skill seems much easier to simulate.
Exactly right. If a complex keyhole procedure is a serial skill, you can use what's called part-task training. You teach each component step by step, not tying, then handling instruments in a tight space, then getting the portals right before you put it all together.
Hmm.
And because the environment is closed, you can create quite realistic, stable training setups outside the operating theater. The sources also mention underlying abilities based on taxonomies like Fleischmann's, things like having a steady hand, good finger dexterity, being able to aim precisely. These are the building blocks needed for the skills. Recognizing this can help in selecting trainees or figuring out what specific areas someone needs to practice more.
So beyond the physical mechanics, what about the mental side? Things like attention, maybe stress or arousal levels. How do they affect a trainee surgeon's performance?
Oh, they're absolutely critical, particularly when you're just starting out. Chapter 2 makes the point that beginners have quite a limited amount of attention they can spread around. When they're faced with a complex task like finding their way inside a joint and using instruments at the same time, it's easy for them to get overloaded.
Right.
Their conscious mind is totally focused on just making the basic movements. That's why simplifying the tasks at the beginning is so important. And the idea of arousal or alertness is also key. There's a sweet spot, an optimal level of arousal for learning and performing well.
Like the Goldilocks zone.
Sort of, yeah. Too low, and you're just not engaged enough. Too high, maybe too stressed, and you get what's called perceptual narrowing. You focus intensely on one tiny thing and miss other important information around you. Helping trainees find that balance in training is crucial for managing stress and keeping their attention effective when things get serious.
Right. Focused, but not panicked. Okay, so understanding the type of skill and the factors, like attention is one thing, but how do people actually learn these motor skills? The sources talk about the Fitz and Posner three-stage model as being pretty central here.
Yes, it's a really foundational model in motor learning, and it applies surprisingly well to learning surgical skills. The first phase is the cognitive stage. This is where the trainee is really trying to get their head around the skill, intellectualize it.
Thinking it through.
Exactly. They're actively thinking, what do I need to do? How do I do it? What's the sequence of steps? Which instrument is which? Their movements at this stage are often quite hesitant, clumsy, inefficient, and they make a lot of mistakes. They rely heavily on instructions and feedback from the trainer, constantly asking, is this right? What do I do next?
Lots of conscious effort involved. Then they progress to the associative stage.
That's right. In the associative stage, with practice, the trainee starts to smooth out the movement pattern. They begin linking the different steps together more fluidly. And really importantly, they start to recognize their own mistakes and try to fix them themselves without needing someone telling them every time.
Ah, self-correction.
Yes. Their movements become more consistent, quicker, more efficient, but they still generally need to pay conscious attention to do it right. They're basically associating the feeling of their movements and the visual feedback with the result they want.
And the final stage is autonomous. That sounds like where the real experts operate.
Absolutely. Getting to the autonomous stage means the skill has become largely automatic. The movements are smooth, very efficient, and need hardly any conscious thought. And this is key because it frees up the surgeon's brain power to focus on higher level things. Watching the patient's overall condition, making complex decisions if something unexpected happens, anticipating problems, or even teaching someone else while they operate. The sources rightly point out that while you can see quick improvements in the early stages, cognitive to early associative, getting from that middle associative stage to being truly autonomous, is a much, much slower journey. It takes a huge amount of focused, deliberate practice over a long time.
That point about the slow climb to autonomy is really important, isn't it? It highlights why training can't just be about watching a few times. It needs that structure and repetition. And this leads us nicely into how you design the training courses themselves. Task analysis and specific teaching steps are mentioned quite a bit in the sources.
Yes, chapters 2 and 8 both get into this. Task analysis is basically breaking down a complex surgical procedure into its smaller, manageable parts. For serial tasks like arthroscopy, it's often better, especially for beginners, to use part-task training.
So focusing on the bits.
Exactly. You concentrate on mastering individual components, maybe just not tying first, then handling instruments in a tight box trainer, then getting the entry portals right before you try the whole operation. The logic is that mastering the parts makes learning the whole thing much less daunting.
Makes sense.
But there's a slight catch. You need to make sure that practicing the parts doesn't somehow mess up the trainee's ability to put it all together smoothly later. Transferring those part skills back into the complete, integrated procedure needs careful thought by the trainer.
And Chapter 2 gives a really practical framework for learning a skill, doesn't it? It details specific steps trainers should take trainees through. Conceptualization, visualization, verbalization, practice.
Yeah,
These sound like the core building blocks.
you really are. It's a structured way to develop these psychomotor skills.
Yeah.
It starts with conceptualization. The trainee has to understand the basic anatomy, the steps of the operation, the instruments they'll use, and the reason why they're doing certain things. They need the theory first.
Okay.
Then comes visualization. Actually seeing the skill done correctly, either watching someone live, watching a video, or even just picturing it clearly in their mind. Having that mental template is vital. Next is verbalization. The trainee should be able to talk through the steps of the procedure, explain what they do and why. The sources suggest that if you can say it, you're much more likely to be able to do it correctly.
Saying it forces you to process it properly, and then, obviously, practice is key.
Absolutely. But the practice needs structure. Correction and reinforcement are critical. Giving immediate, specific feedback when things go wrong, and praising correct actions helps the trainee fine-tune their movements. That feedback loop is essential for moving through those learning stages.
Right.
Through this whole process, the trainee works towards skill mastery in a safe training setting, meaning they can do the skill reliably and accurately without supervision there. The ultimate aim, of course, is skill autonomy, being able to do it safely and reliably in a real operation. This whole framework fits really nicely with the Fitz and Posner stages, giving trainers concrete steps to follow.
It provides a clear path. And Chapter 5 connects this back to Rasmussen's model of skill-based, rule-based, and knowledge-based behavior, which seems very relevant to surgical competence.
It really does. Skill-based behavior is that automatic, smooth performance of routine things, like tying a standard surgical knot. This is where lots of repetition and simulation are really effective training methods. Rule-based behavior is more about following set procedures or recognizing specific patterns, seeing a particular type of meniscus tear, and knowing the standard way to repair it. You can train this through things like case discussions, online learning modules, and simulators that are realistic enough to show different pathologies.
And knowledge-based behavior, that sounds like the top level.
It is. This is the ability to deal with completely new or unexpected situations, complications, or weird anatomical variations, where there's no pre-learned rule or automatic skill that fits. It requires pulling together theoretical knowledge, past experience, diagnostic skills, and the ability to think through a problem logically, often under pressure.
Right, thinking on your feet.
Exactly. This is often what marks out a truly expert surgeon, and it's the hardest thing to train and assess properly outside of a real operating theater because it demands flexibility, problem solving, and judgment. Simulators can help a bit, but the full complexity often only happens live. This really underlines the point that proper surgical training has to go way beyond just the hands-on skills.
That's a really powerful distinction. It shows that even if you've mastered the technique, judgment is still paramount. And knowing who you're teaching is vital too, isn't it? Especially when training adult learners, as Chapters 2 and 8 highlight.
Absolutely. Adult learners aren't like kids in school. They usually come with existing knowledge and experience. They tend to be quite independent and self-motivated, and they really need to see the relevance and practical use of what they're learning. They're often very goal-focused and appreciate a practical approach. Trainers need to respect that background and create a learning atmosphere that acknowledges their professional standing. Chapter 2 mentions the importance of understanding different learning styles. Some people are very analytical, like step-by-step instructions. Others are more big picture, needing the overview first.
Okay.
And Chapter 8 adds the really crucial idea of creating an educationally safe space. This means building an environment of mutual respect, openness, trust, and collaboration, where trainees feel okay asking questions, admitting they made a mistake, and getting feedback without feeling judged or humiliated. Learning complex skills makes you feel vulnerable. That psychological safety is essential for effective learning.
Creating that safe space sounds fundamental. Okay, so we've talked about the goal, the complete surgeon, the science of how skills are learned, the stages people go through, and the principles for designing good training, including knowing your audience. How do we actually do this training in practice? What sorts of tools and environments are out there, and how do we know if they're working?
Right, this brings us to the actual methods of training and how we assess them, which are covered in Chapters 6, 7, 9, and others. Traditionally, surgical training was heavily based on the apprenticeship model. You
Hmm.
watch, then you assist, then you do it yourself with less and less supervision.
The classic see one, do one, teach one.
Something like that, yes.
Yeah.
And while it's invaluable for getting real-world experience, Chapter 9 points out a major downside assessment in that model is often very subjective. It depends heavily on the supervising surgeon's overall impression, which can vary hugely based on their own experience, biases, even how good they are teaching.
And this lack of consistency, I suppose, led to developing more objective ways of doing things.
Precisely. Training methods now span a whole range. You still got traditional approaches like using animal models, though that's less common now for ethical reasons, or human cadavers. Cadavers offer great anatomical realism, but they're expensive, hard to get hold of, and obviously don't bleed or react physiologically.
Right.
Then you have simpler bench models, as mentioned in Chapter 6, like the FAST system. These are often physical models made of plastic or similar materials, good for practicing very basic, isolated skills like tying knots or manipulating instruments in a box.
And the big development seems to be simulators, right?
Indeed. Chapter 7 really presents simulators as a very promising path for modern motor skills training, especially for the early and intermediate stages of learning. They offer the chance for standardized, repetitive practice in a controlled setting without putting any patients at risk.
Okay.
The chapter talks about two main types: physical simulators and virtual reality or VR simulators. Physical ones, like the passport system they mentioned, use realistic models of joints or body parts, often with instruments that have sensors to track movement, force used, efficiency, giving you objective numbers on performance.
And virtual reality simulators must be taking advantage of all the computing power we have now.
Exactly. Since arthroscopic surgery is already done looking at a 2D screen, VR simulation can create a very realistic visual experience. Systems like Retamed ArthroS, Cemendo, ArthroMentor, ArthroSim, they use sophisticated graphics to recreate the view inside the joint and provide interactive exercises for specific procedures or skills. Many of them can give automated objective feedback on things like how long it took, how much the instruments moved around, movements outside the camera view, even simulating damage to tissues. This lets trainees practice specific bits over and over and get immediate data-based feedback.
That instant feedback and hard data must be incredibly useful for the trainee. What are the main advantages of using these simulators?
Well, they provide a safe space for that deliberate practice and learning from mistakes. They offer standardization. Every trainee gets the same virtual patient and the same task, so you can compare performance fairly. They can objectively measure how well someone's doing and track their progress over time, which is vital for assessment.
Right.
They let you focus on repeating tricky steps until they're mastered. And importantly, studies mentioned in the sources suggest that skills learned on properly validated simulators do seem to transfer to better performance in the actual operating room, at least for the basic to intermediate level skills.
But they presumably have limitations. They can't be exactly like real surgery.
Not yet,
Oh.
no. And that's a key challenge the sources discuss. Simulators for less common joints beyond the knee and shoulder are still pretty rare. The anatomical realism of physical models can be limited for really complex procedures. Putting sophisticated sensors into these models can also be incredibly expensive.
Okay.
For VR simulators, you need extremely high-quality graphics to represent anatomy accurately. If it's not detailed enough, trainees might learn to identify structures incorrectly. There are also ongoing challenges with cost, making them widely available, and properly integrating them into established training programs and certification processes. And crucially, while they're excellent for the hands-on skills and maybe some rule-based decision-making, simulators still struggle to recreate the full context needed for that knowledge-based behavior, dealing with unexpected bleeding, sudden anatomical oddities, or complex team interactions. Real-life experience is still essential for developing that top-level judgment.
So simulators are a really powerful part of the training toolkit, especially for building foundational and technical skills, but they don't remove the need for structured clinical experience. Which brings us neatly to measurement. How do we know objectively if the training's working and if a trainee is actually competent?
This is where objective assessment methods are absolutely vital, as discussed in Chapter 9. To get away from that subjective, I think they're ready kind of evaluation from the apprenticeship model. Tools like global rating scales, GRS, and OSATs, that's objective structured assessment of technical skill, have been developed and validated.
OSATs.
Yes, OSATs is often mentioned as the most widely accepted tool globally for objectively assessing clinical skills in surgery.
How do these tools actually work? What are they measuring specifically?
Well, they typically involve trained assessors, watching a trainee perform a specific task or procedure, either on a simulator or, sometimes carefully, in a real clinical setting. The assessors use a predefined checklist or scale, often a 5-point scale ranging from novice to expert, to rate specific aspects of the performance.
Okay, like what sort of aspects?
Common criteria you'd find in many GRS and OSATs tools include things like how efficiently they handle the instruments, the overall flow and smoothness of the procedure, whether they're gentle with tissues, avoiding unnecessary damage, their time and motion efficiency, whether they seem to be planning ahead, and increasingly, measures of how much help they need, their autonomy, and overall safety.
Right.
The sources give specific examples like OK, BK, SARSS, ASA, OAS, and ASSET, and highlight that these tools have been shown to reliably tell the difference between trainees at various levels of experience and track their learning curves effectively. They provide concrete, observable actions to rate, which cuts down on relying on just a subjective gut feeling.
That move towards objective, criteria-based assessment feels absolutely fundamental for ensuring consistent standards, doesn't it, across different trainees and hospitals? And these standards then need to be captured within a formal structure, a curriculum. Chapter 4 talks about curriculum development, describing it as still quite complex, maybe even a work in progress sometimes, even for established surgical fields.
It really is. And one of the most critical points David Pitts makes in Chapter 4 is the very common confusion between a syllabus and a curriculum. This isn't just playing with words. Getting this wrong can mean training programs just don't achieve what they set out to do.
Okay, so what is the essential difference then?
Well, a syllabus is basically just a list or outline of the content that needs to be covered, the topics, the procedures, the areas of knowledge. It's the what. A curriculum, on the other hand, is much, much broader. Drawing on definitions like the one from the UK's General Medical Council, a curriculum is the whole package.
The whole package.
Yes, it's a complete statement of the intended aims and objectives, the why behind the training, the content, which includes the syllabus, the what, the planned learning experiences, the how and where, things like lectures, simulation sessions, supervised operating clinics, the desired outcomes, what the trainee should actually be able to do and be like by the end, and educational processes used. The teaching methods, assessment strategies, how feedback is given. A syllabus is just one ingredient. The curriculum is the entire recipe for producing a competent surgeon.
That's a much more comprehensive definition. Given that, why is having a formal, properly thought-out curriculum so important, especially for a subspecialty like orthopedic sports medicine?
The sources give several really strong reasons. First, it's absolutely essential for planning postgraduate medical training properly, especially when resources like money, training time, and access to operating theaters or simulators are limited. A clear curriculum helps make sure these resources are used effectively and training is structured efficiently. Second, it's fundamental for governance and being accountable. Regulatory bodies, hospitals, and the public need assurance that training programs are solid and produce doctors who are demonstrably competent. Patients need to be able to trust that their surgeon has been trained to a recognized standard.
And for a field like sports medicine that overlaps with so many others?
Yes, it's vital there too for supporting collaboration between specialties. People coming into sports medicine might come from general orthopedics, others might be sports physicians moving into surgery. A curriculum defines who's eligible, what background knowledge they need, and the specific training pathway.
Okay.
It also clearly spells out the unique knowledge, skills, and judgment that a qualified sports medicine surgeon possesses, clarifying their distinct role in the broader medical world and making teamwork and referrals smoother. It basically manages expectations for everyone involved, trainees, trainers, and colleagues who refer patients.
Setting one up sounds like a massive undertaking, though. The chapter warns against just getting the most important people together or trying to borrow one from somewhere else.
It is definitely complex, and it needs specific expertise that goes beyond just being a good clinician. The warning about just inviting senior, busy surgeons who might not know much about curriculum design or have the time is spot on. The recommendation is for a small, dedicated group with the right teaching and administrative skills, working towards agreement.
Right.
And borrowing a curriculum is tricky because training programs are very context-specific. They're designed for a particular healthcare system, patient population, funding level, existing facilities. A borrowed one just won't fit your situation properly. And crucially, if you haven't gone through that tough process of debating, defining, and building it yourself, you won't have the deep understanding needed to implement it well, adapt it over time, and keep improving it. It's described as a marathon, not a sprint needing real sustained effort.
And even when you've built it, actually getting a new curriculum up and running must present its own set of challenges. Managing that change.
Absolutely. Implementing change, especially big systemic changes in medical education, always faces potential hurdles and resistance. Chapter 4 talks about needing to think about the impact on existing structures, like hospital departments or university roles, systems, how training rotations are organized, how assessments are recorded, tasks, new jobs for trainers or administrators, and critically, the people involved, trainees, trainers, admin staff getting their buy-in, managing their workload, showing them the benefits. That transition period needs careful planning, very clear communication about why the change is happening and what the benefits are, and support systems to help everyone adjust. You really need to sell the value to all the different groups involved.
So the curriculum gives us the big picture roadmap, the goals, content, experiences, processes. Assessment tools give us the objective measures to track progress and competence along that road. And the endpoint of this whole journey is usually formal certification.
Exactly. Chapter 10 gets into the vital role of certification. Its main purpose is for society. It's a guarantee that surgeons have reached the level of competence required by regulators and professional bodies to practice safely and effectively. It marks a fundamental shift away from training models based purely on time served.
Right, where you just assumed competence after X number of years.
Precisely. The shift is towards competence-based assessment, where passing rigorous exams and assessments is what really counts.
Okay.
The sources, particularly looking at the European context with bodies like UEMS and EBOT, explain that while you often need a minimum training time, say a 5-year residency, to get enough experience, it's successfully passing structured board exams and assessments that really signifies you've met the basic certification standard. Subspecialty certification, like in sports medicine, might then be an extra formal qualification based on completing a specific accredited subspecialty curriculum and assessment process showing advanced expertise.
And going back to an earlier point, certification isn't just about the technical surgical skill itself, is it? It includes that wider definition of competence we discussed.
Absolutely, and this is so important. Certification aims to assure the public that a surgeon isn't just technically good at doing operations, but is also qualified to use appropriate and sound judgment throughout the whole patient journey.
So, from start to finish.
Yes, from the initial assessment and diagnosis, deciding if surgery is even the right choice, picking the best procedure if it is, carrying out the operation safely, and then planning and overseeing the really crucial post-op rehab phase. Chapter 10 echoes this, talking about complex decision-making involving multiple layers of judgment. Certification, therefore, has to try and evaluate these less tangible but absolutely critical thinking and professional skills alongside the technical ability.
It really brings us back full circle to that idea of art versus science that's mentioned near the end of the source material. Certification can measure the science, the knowledge, the technical skills, but how does it capture the experience and the beginnings of that art or advanced judgment needed for situations you haven't encountered before?
That is the constant challenge, isn't it? The sources do acknowledge that the art of surgery, that sort of intuitive, adaptive element, is often something acquired over a long career, built on a huge amount of experience. However, they also make the point that mastering the scientific knowledge and the fundamental technical concepts and skills through structured training is the absolutely essential foundation.
You need the foundation first.
Exactly. Certification tries to validate that the surgeon has built that foundation and has the potential and the necessary basic judgment upon which that art can develop later. It's about making sure they meet a high standard covering knowledge, technical skills, professional attitude, and competent judgment to function as a safe, competent specialist or super specialist. Ultimately, this whole formal process curriculum, objective assessment, certification, it's all about protecting public trust and ensuring high-quality healthcare in a field that's becoming ever more specialized.
It definitely feels like a continuous cycle of defining and refining what surgical excellence actually means in a world that's changing so fast. We've covered a huge amount today, from ancient Greece right up to modern teaching science and certification issues. Let's switch gears for a quick lightning round, just some sharp answers drawing on everything we've discussed. If you had to pick just one concept from all this material for trainers in orthopedic sports medicine to really focus on, what would it be?
I'd say understanding and really applying those adult learner principles, especially creating that educationally safe space. You absolutely have to meet the learner where they are.
Okay, good one. And for a trainee listening right now, what's one quick win they could put into practice straight away to help improve their motor skill learning based on these principles?
Consistent, deliberate practice, definitely, but combine it with structured mental rehearsal. Just take a few minutes before any practice session or even before a real case to mentally walk through the steps, visualize yourself doing them correctly, and maybe even say the process out loud or in your head.
Simple but effective. Are there any particular tools or frameworks mentioned that stand out as especially valuable for assessing surgical skills objectively?
Oh yes, the global rating scales, GRS, and particularly OSATs, the objective structured assessment of technical skill, are repeatedly highlighted as the key frameworks for moving assessment beyond just subjective opinion.
Right. What's the crucial takeaway about the difference between a syllabus and a curriculum that everyone involved in training really needs to get?
That a syllabus is just a shopping list of topics. A curriculum is the entire strategic plan for the educational journey. Aims, objectives, content, how you learn, what the outcome should be, how you assess it. Don't mistake the list of ingredients for the whole recipe book.
Nicely put. Okay, finally, looking ahead, what role do you think simulation will play in the standard pathway to becoming a certified surgeon in the future?
An absolutely fundamental one, I think, is becoming pretty much essential for standardizing those early stages of technical skill training, allowing safe, repeatable practice, and giving that objective feedback. The big challenge now is getting them better validated and properly, seamlessly integrated into the formal certified curricula.
Excellent. Those are really valuable practical points. Let's just quickly summarize some of the main takeaways from our deep dive for everyone listening. First, we established that being a top orthopedic sports surgeon is a really complex, multi-layered role. It needs that mix of general orthopedic knowledge, very specific sports medicine understanding, covering everything from conditioning principles to anti-doping rules, finely tuned technical surgical skills, and those vital non-technical skills like communication, teamwork, leadership, situation awareness, and solid decision-making. The triangle pearls idea from the sources gives a great visual for that.
Yes, and absolutely key to learning the technical side is understanding motor learning principles. We talk about how surgical skills are often classified serial, closed, fine motor skills, and how learning happens in stages. Cognitive, where you're thinking hard about every step. Associative, where you start smoothing things out and self-correcting. And autonomous, where it becomes automatic, freeing up your brain for higher-level thinking. Using structured practice like conceptualization, visualization, verbalization, and practice is crucial for moving through those stages.
We also looked at the importance of structured training environments and the tools we use. That includes older methods like cadavers or bench models, but increasingly the vital role of simulators, both physical ones and virtual reality. While simulators offer massive benefits for standardization, safety, and objective feedback, especially for basic skills, we also noted their current limits in fully recreating complex real-life situations and developing that higher-level knowledge-based judgment.
And moving beyond subjective gut feelings in assessment is so important for consistent standards. We discussed how objective assessment methods, like global rating scales and especially OSATs, are essential tools now for reliably measuring technical competence and tracking how a trainee is progressing against clear, defined criteria.
And finally, all of this sits within the crucial framework of having well-developed curricula and formal certification processes. Understanding that key difference between a syllabus, just the content list, and a curriculum, the complete educational strategy, is vital. These formal structures are essential for planning training effectively, ensuring accountability, helping different specialties work together, maintaining high standards, and ultimately building and keeping public trust by certifying that surgeons have the necessary blend of knowledge, technical skill, professional attitude, and clinical judgment.
It's certainly a field of education that's constantly evolving to keep up with the demands of modern surgery.
And a really fascinating one to explore. Thank you so much for guiding us through all that material and sharing such valuable insights today.
It was my genuine pleasure. Thank you for having me.
If you found this deep dive valuable, perhaps consider rating the show or sharing it with a colleague who might find it useful too. And as we finish up, here's something to think about, drawing from some of the tensions we explored today. We know the ultimate goal of certification is to guarantee not just technical skill, but also sound surgical judgment and decision-making. We also heard experts describe top-level sports medicine practice as a mix of science, loads of experience, and sometimes that element of art. So the question is, how effectively can formal training programs, which naturally have to focus on measurable skills and standardization, actually foster and assess those less tangible, experience-heavy qualities, the surgical art, and the adaptable judgment you need when faced with something completely unexpected in the operating theater? Where does the formal curriculum stop, and that lifelong journey of developing real surgical wisdom actually begin. That's all for this deep dive. You can find us wherever you get your podcasts. Do subscribe so you don't miss our future explorations designed to get you well informed fast.